Our next talk is from our worthy and renowned consultant nuclear medicine physician with having more than 30 years experience. He has been serving as former DG NMO at the PAC, and he's currently working as consultant nuclear medicine at Inmol, Lahore. Dr. Ahmad Qureshy, so kindly please come on the stage. He'll be delivering his talk on response assessment in the solid tumors.
Assalamu alaikum, dear colleagues. Chair, thank you for inviting me for the talk. I've got a very simple talk, whatever I've been listening since morning. So my talk is about the various criteria we use for the response assessment for solid tumors using PET-CT. Our radiology colleagues, they have developed different criteria on which they can assess the various imaging modalities, like in the breast, colonography, hepatocellular carcinomas, etc., just to standardize the various reports they are making. And then in case of tumors, they have got RECIST criteria, which are there in use for radiology modalities only, in which complete response, partial, progressive disease, or stable disease are defined. Usually these are all measurable things on CT or MR, and they are using sum of diameters, etc. For nuclear medicine people, this is not possible because what we are measuring is different. Here we are talking about PET criteria, which in metabolic response in case of FDG uptake, and complete metabolic response, partial metabolic response, progressive disease, or stable. So in our oncology setups, they need the help from our colleagues in nuclear medicine if they can give us the idea whether the patient is responding to the treatment or not. So SUV was the only criteria in which whether it was malignancy or benignity of the lesion which was seen. And when we started PET back in 2010-11 in Mole, the main question from our oncology setup was always whether this lesion is malignant or not. And 2.5 was the SUV criteria, which was a magical figure. And we always said that this is not a standardized uptake value, rather it should be called silly uptake value, because it's not cut off actually. And here, if you see the changes in FDG uptake in the scars or recurrence of the disease, then there was a considerable overlap. There was considerable overlap of the lesions in whether they are tumor itself or they are only non-remnant scars there. So comparison of RECIST and PERSIST criteria. It has been now known that the concordance of responses between RECIST is not excellent, and PERSIST is maybe having much more advantage as compared to RECIST or radiological. My presentation now, I will try to cover as much as possible if Dr. Ambreen allows. So I will try to cover Hopkins criteria, Duval criteria, Lyric criteria, and impetus criteria. Most important and most used is the Duval criteria, of course. Hopkins criteria, basically it is a criteria in which head and neck cancers, they are evaluated of squamous cell carcinoma, whether the disease is present or they are not. Because usually these patients are treated with radiotherapy, the remaining inflammation, the remaining disease that can have to be differentiated with the help of PET, FDG PET, and therapy response is important for the oncology people. So that was introduced somewhere in 2014, it's almost 10 years, and here in what they were comparing it with, first of all, the tumor sites, whether it's primary or whether it's lymph node, and second, activity present FDG uptake in the internal jugular vein, and third is the liver. And A score is assigned for the primary tumor and metastatic lymph nodes. So here, Hopkins criteria is from Johns Hopkins University. So Hopkins criteria 1, when uptake is less than internal jugular vein. And of course, we need a contrast study in order to identify the vessels and in order to mark them and calculate the SUV overhead. Then Hopkins criteria, uptake in IGV is like less than liver, a likely metabolic complete response if it is there in the lymph nodes or in the primary site. And Hopkins criteria 3, when ROI is slightly uptake in more than liver or diffuse, then again, if the radiation has been given, then it's a post-radiation inflammation rather than a tumor itself. While on the other hand, these two, uptake mortality greater than that of the liver and focal, these two have to, then it will be called HC4, and usually it is like residual disease. And if it's like 5, then the uptake is much more than liver, and it's also focal, then definitely it's a residual tumor. So in these 3 will be like post-therapy changes, and these 2 be residual disease. So just to make you understand what I have already enunciated, the baseline scan, primary tumor here you can see, and lymph nodes which are present, it's an FDG image, and metastasis. And after certain time, when the radio chemotherapy has been completed, you can see there is complete resolution of a tumor here, but there's like lymph nodes, they are still positive. So it's a Hopkins score 5, and persistent metastases are there. Here you can see. Though it has shown reduction, but it is still present. Again, another case in which a lingual tumor is there in here with metastasis in the neck nodes on the left side, and after a certain period of chemoradiotherapy, re-evaluation was done. The treatment response is there here in the primary site, but tumors are still present. So, post-therapy Hopkins criteria on FDG may identify clinically unsuspected residual disease in up to like 20% of the patients. So, this is very good criteria. We can, utilize it. And if we look at since 2014, multiple papers have been published, and they have validated these scores altogether in all the post-therapy or therapy response, post-treatment criteria. So coming to Duville, which is like there for the last now almost 15 years now, back in 2009, now it's a classification system which reliably describes the residual disease of FDG in lymphomas, whether it's non-Hodgkin or Hodgkin's lymphoma. So here we have got 2 reference points actually. One is mediastinal blood pool. Usually you withdraw it on the arch of aorta, and we spare the aortic walls, and only the blood pool is measured. And liver, somewhere in segment 6, 7, where no other disease is present, no other disturbance from the guts or like from the kidneys. So there we draw these ROIs. So again, similar to that Hopkins criteria, we have got 3 grades in which we call them negative, and 2 grades in which they are positive. So here you can see anything less than liver or equal to liver is negative, and if it's moderately higher than liver or markedly above the liver, then it will be called positive. Just to show the example, Duville score 1, that negative, you can see the CT showing some nodes present here, and but they have got very low activity and less than liver. So they are all called negative. While on the other hand, if it's more than liver and it is showing much more high activity, then 4 and 5 Duville scores are given. So according to that, Deauville score 1 to 2, 3 will be no lesions, no bone marrow involvement, complete response. Then partial, when 4 or 5 will reduce uptake from the baseline, residual bone marrow FDG uptake reduced from baseline, no new lesions, then we call it partial response. Stable disease, I will talk about later, and progressive disease, anything which is showing new lesions, whether and the increased uptake as compared to the baseline, then we have call it progressive. And if there is nothing like, then it will be called not fitting in here or here, then stable disease. So whenever we are using persist criteria and we are using like Deauville criteria, have to take certain things into account. First thing, we should be having the same scanner, acquisition algorithm, the reconstruction software and protocol baseline and follow-up, so that you can report the scoring in a better way. And then we have to make sure that fasting is there 4 to 6 hours and glucose levels are like measurable less than 200. Uptake period, usually we know that we cannot ensure that exact same time is patient is imaged at the time when maybe we have got a heavy list, we have got a problem with our scanner, but we try to make it like 50 to 70 minutes after FDG injection, and then of course the Deauville criteria will be easily applicable. So a role of interim PET for the assessment of treatment response, that is important, that if we start at the baseline, we have got certain number of cells which are showing FDG uptake, and over a period of time, when the end of therapy, the cells may be like getting killed and complete cure is achieved. And on the other hand, we have got certain group of patients in which the response to the treatment may not be very good. So here the usual size at the diagnosis and the cure, somewhere in between is the detection limit of PET. So in these two A and B groups, we have got decrease of uptake on the cancer cells, which is rapidly decreasing, and they are like lying within the low detection limit of PET. These two will ultimately go towards cure, and that's how the prognostic value of Deauville criteria and PET is established. On the other hand, if we have got, sorry for that. Okay. So here we can see that the response to the treatment is not good enough at interim PET. That's the green line, and you can see that it's gradually going down. And when interim PET, usually after 2 to 4 cycles, we do, and we still find evidence of disease, then we call it like they're a non-responder, and maybe the cure will not be there till the end of the intended treatment. So escalation of therapy after 2 to 4 cycles or de-escalation of therapy is decided on these criteria by the oncology setups. So one thing, this is lymphoma response to immunomodulatory therapy criteria LYRIC that was proposed in 2016. As I've already mentioned, the Lugano criteria and Deauville criteria, which I've already mentioned, there is slight change because of the immunotherapy. In the tumor response is not that like of routine chemotherapies, and these checkpoint inhibitors may cause increase in availability of FDG to the tumor cells, whether or in the surrounding inflammatory areas. Here, for example, if conventional cytotoxic therapy, the size FDG uptake goes down, but in we are talking about immunotherapy, then there will be edema. Apparently, these cells which are non-cancerous, they will take FDG uptake, and we can go for we can see something like tumor flare phenomena. And we have to be careful about that, labeling the patient in such case when immunotherapy is being given, then we should not be labeling the patient as having progressive disease. So 4 possible response patterns in immunotherapy are like shrinkage of the initial lesions without new lesions, no change or stable disease, initial increase in total tumor burden and subsequent response, and response despite having new lesions. So in this case, Lugano criteria are a little bit modified in immunotherapy, and indeterminate response was introduced where there is an increase in overall tumor burden, interval development of new lesions, or growth factors on one or more existing lesions, interval increase in FDG uptake on one or more lesions without any morphological change. So here they say that if we label the patient as like IR, then a new PET scan is advised after 12 weeks or later. And if clinically indicated, you can do it earlier. So if pseudo-progression has to be ruled out with the help of PET, and the number of patients which are affected are less, but still you have to understand that this is some finding you have to give importance. So here you can see that these criteria are not yet been validated completely, but when we are interpreting our PET images, then we have to be careful about these. Here, for example, this is one patient, baseline, 4 cycles given, and immunotherapy, and 8th cycle. Here you can see the disease which is present here in the pelvis, in the inguinal area, left side, and in chemocycles, the number of lesions have increased. So after like 12 weeks, there is complete disappearance. Now we can call it complete remission. But on the other hand, if we have got disease which is decreasing but still present and it will progress, and here we can label whether the patient is having complete response or progressive disease. Dual criteria, its modifications have been utilized in multiple myeloma as well. In 2018, it was first introduced in Italian studies, and it for the response evaluation and monitoring and surveillance. Again, same criteria, uptake less than liver or more than liver. And here the impetus, these are called impetus criteria, Italian myeloma criteria for PET use in multiple myeloma, although it's not exactly a solid tumor, but plasmacytomas, like the sequel of multiple myeloma, their dual criteria can be used for the involvement of bone marrow, of the bone itself, of the nodes, extramedullary, etc. So metabolic status of the bone marrow, positive bone lesions, fractures, extramedullary disease, or paramedullary disease. They are all rated according to the Duval scores. And whenever we are preparing our report for in the case of multiple myeloma, then diffuse marrow uptake, focal bone lesions, lytic bone lesions, extramedullary, extranodal, all these diseases have to be mentioned whether they're present or they're absent. I think I should stop here.